Yeah. Yeah.
I'll do a little spill about myself.
Yeah.
All right, ready to get started? If you want to take a seat. Okay, I guess we'll go ahead and get started. Thank you for coming. If you have a cell phone, if you would like to silence it or turn it off during the presentation, it'd be greatly appreciated. Zoomers, you're muted. Please stay muted. At the end of the presentation, there's questions and answers. And if you want to type your questions in the chat, I'll monitor that and we can ask the speaker. We're trying something new in the room about having a microphone in the middle. So when we go to questions and answers, if you have a question, if you want to go to the mic during that time and ask your question. If you can't, it's hard to get up and you would like me or someone to come to you with a mic, raise your hand and we'll do that too. So, but we're trying it out and seeing how it works instead of me running around the room with the mic. It might save some time and things like that. Okay, so this is our facilitator, and he will introduce himself and introduce our speaker.
Thanks, Pam. Hi, so my name is Ken Rand, and it's a really great pleasure for me to introduce Dr. William Miles, who is a professor of cardiology in the Department of Medicine at the University of Florida, and he is the Silverstein Chair for Cardiovascular Education. So Dr. Miles received his undergraduate degree from the University of Indiana and then did his medical training, both medical school and house staff training, internship residency at Medical College of Virginia. He then went back to Indiana University Hospital for his cardiovascular fellowship training, and then practiced electrophysiology of cardiac medicine there for the next 16 years. He then was recruited to come into a private practice in Fort Myers in Florida, where he remained for about, what was it, 8 years, 7, 8 years. But the lure of academia was too much, and the allure of the University of Florida was too much. So he chose to come back to academic medicine, and he has been here since 2005. I will say he's had a spectacular career, published over 160 peer-reviewed papers. So Dr. Miles is really a complete expert in the field of heart rhythms. Since we all have a heart and all of us have a rhythm, this is going to be some information you will definitely want to hear and take away from here. So thank you, Bill.
Does this microphone work also? Well, thanks for having me. This is actually enjoyable. Okay. This is actually very enjoyable, so I appreciate it. Atrial fibrillation is so common and so pesky that I thought it was a pretty good topic. It's maybe a little boring. Ken warned me not to get too technical because he looked at my slides, but I think there's a little bit of method in my madness with the slides, but yell if I'm too technical. I'm going to sort of go through this like I might go through it with a patient who comes in with atrial fibrillation. So where do I point this then? Is it the arrows? Oh, okay. It wasn't me. That was you, I think. All right. So just a little review for those of you who don't remember dissecting your frog or whatever. The electrical impulse starts in the atrium at the sinus node and goes down through the atria. So the atria contract. And then through an AV conduction system, the impulse goes down to the ventricles and make the ventricular muscle contract so that blood is pumped around the body. But when you have atrial fibrillation, things sort of go kaput and you have chaos here in the atria, and then you have an irregular rate, usually a rapid rate because of the rapid conduction of the AV conduction system. And a lot of people get very symptomatic from that. And so I don't want to teach electrocardiography, but we're now encouraging people to get devices that actually give electrocardiographic strips if they think they're having palpitations or arrhythmias of some sort. And we can diagnose the arrhythmia by their putting fingers or pressing a button on a smartwatch and getting an EKG. So I'm going to do a brief EKG course. This is atrial fibrillation. I pushed the wrong button. And notice, doggone it, notice that it's irregularly irregular. Okay? So each sharp deflection, well, maybe I should use the other one then if I'm going to have to turn, but each sharp deflection is contraction of the big ventricles. And in between there should be a smaller deflection, which is the contraction of the atria. And the only thing you have here is all this squiggle in between the contractions of the big ventricles. And so that's the indication electrically on the EKG that the atria are fibrillating. Now I'm having trouble getting it to move again. Can you advance it for me? We're going to go slow if I can. There we go. And the reason I do this is that you can have devices at home that help you whether you have atrial fib or not. And here's a recording from a home handheld device that shows the little P wave, which is atrial contraction, followed by the sharp, what we call a QRS, which is ventricular contraction, and premature atrial beats. And then that leads to an irregular rapid rhythm that I'm trying to get you to recognize as atrial fibrillation. So here's that same patient that I showed you before during atrial fibrillation, irregularly irregular, squiggly stuff in between the QRS complexes. But when that same patient's back in sinus rhythm or normal rhythm, you can see this little thing we call the P wave. That's the atria contracting normally, followed by ventricular contraction. So this is what you don't want. This is what you do want. And people are now using these handheld devices. Who in here has one of the handheld devices? See, so I'm not teaching you anything then. Now, you know, it gives you a little bit of a indication of what it thinks it is, but sometimes you need to have that verified either by being a good electrocardiographer, which some of you might be by this time, or by having someone else look at it. but it shows you whether it's suspicious for atrial fib. All right. So you want me to try to forward it again? Oh, you're starting it over. All right. So one of the things we worry about with atrial fibrillation, though, is if your conduction system is normal, it tends to be rapid. So this is just an example of atrial fibrillation. I'm having trouble too. Atrial fibrillation with rapid ventricular response. Okay, and that's what we don't want, irregularly irregular and rapid ventricular response, and we have to slow that down. So atrial fibrillation is usually symptomatic, but not always symptomatic. Some people have no symptoms, and occasionally we just leave people in atrial fibrillation. If they do have symptoms, they're most commonly fatigue, shortness of breath, exercise intolerance, and palpitations. The symptoms are due to the rapid and irregular ventricular rates, the loss of the normal synchrony between the atria and the ventricles that help the ventricles fill adequately, and sometimes from side effects from all the drugs that we tend to pile on in order to manage the atrial fibrillation. So many people, we leave atrial fibrillation alone, but most of the time, at least in its earlier stages, we try to do something about atrial fibrillation. What are the causes? If you and I could figure out what the real cause of atrial fibrillation is, we could write an article, become famous, and make this the Oak-Hammock atrial fib expertise place or something. But it's associated with high blood pressure, coronary disease, congestive heart failure or weak heart muscle, abnormal heart valve function. Sleep apnea is a very important cause of atrial fib. Thyroid disorders, especially elevated thyroid disorders, but a lot of people with atrial fib have no obvious cardiac structural abnormality to really explain it. And it does tend to run in families. It's multigenetic. But if your mother and your father had it, there's a reasonable chance that you might have it also. And this is just an example of a patient who had a monitor implanted and started to have more and more atrial fib. So this is the number of hours per day of atrial fib. And we were about ready to do an ablation on this patient to try to get rid of the atrial fib when the pre-op lab data that we sent showed that she was hyperthyroid. And when we treated the hyperthyroidism, we saved her an ablation procedure because she went back to very little atrial fibrillation. Now, either fortunately or unfortunately, most people with atrial fibrillation don't have hyperthyroidism, but it should be excluded in everybody. But it's associated with obesity, with sleep apnea, hypertension, heart failure, diabetes, and God forbid, alcohol. So if there's anything that's harder to get someone to do, it's to cut back on alcohol who has a lot of atrial fib. But alcohol is a strong stimulant for atrial fibrillation. And these are some data. I'm not going to go over the graph, but it's to remind me these are some nice Australian data that the more weight you can lose, the better you do in terms of atrial fibrillation if you're overweight. So don't tell my wife. She's a good cook, and I don't want to hurt her feelings or anything. All right? Sleep apnea is really important. A lot of times when a patient presents with atrial fib, one of the first things we do before we start fancy treatments is to say, why don't you go see our sleep doctor because your wife's sleeping in another room because you sound like a hog farm at night. So you go to the sleep doctor and you get fitted with CPAP or something. And if you can comply with what the sleep doctor wants you to do, you might make the atrial fib, you will make the atrial fib better It might not go away completely, but it will certainly respond to our treatments better. So this is one of those more technical slides, so I'll try to be quick. But we look at atrial fib as sort of a stage. And acutely, if you come into the emergency room with atrial fib, we want to get that rate slower and see if we can get you back in the normal rhythm. But long term, it's really important to know that the number one thing here are lifestyle changes in treating of underlying cardiovascular conditions and prevention of stroke. So people do not like the thought of taking blood thinners. Some of them remember Coumadin or warfarin, which was nasty to take. But most of the time, if you need a blood thinner, we can use one of the newer blood thinners, which are easy to take, very safe compared to Coumadin, and are very effective at preventing the stroke risk that's associated in a lot of people with atrial fib. We'll talk about that in a minute. We want to control the rate, and we might want to get you back into the normal rhythm. Some people, we get them back to the normal rhythm. Some of them, we just do rate control. So what do we do when you walk into the office and you're either in atrial fib or we think you've had atrial fib? We do a history and physical exam, check your blood pressure. We ask you about chest discomfort and shortness of breath, looking for other cardiac conditions. We listen to the heart or do an echocardiogram to look for a heart murmur. We want to know whether you have congestive heart failure, weak heart muscle. And even though we're not a sleep doctor, we almost always ask you about sleeping. That's why it's either nice to bring your spouse or you might want to tell your spouse to stay home, depending on whether you want to tell us the truth or not. All right, we get thyroid function studies. We do an electrocardiogram, and we might get a long-term electrocardiogram, or we might ask you to bring in some of your computer-generated tracings that you get at home. We get an echocardiogram or a heart sonogram in order to look at heart muscle function and heart valve function. And if there's some question or you might have coronary disease, we may do some sort of stress test. So, 3 principles, 3 things that we have to do therapeutically in someone who presents with atrial fib. The number one thing is prevention of clot formation and stroke. We'll talk about that in a minute. The second is slowing down the rate during the atrial fibrillation. And the third is deciding whether to try to restore and maintain the normal rhythm, which is called sinus rhythm. And how easy is it to restore and maintain? And should we use drug therapy or ablation therapy in order to restore and maintain? So I got this from Sam Sears, one of our psychologists, that the boogeyman of atrial fib is stroke. So the thing that scares us and the thing that scares our patient, sometimes it's stroke, sometimes it's the thought of a blood thinner. But when we start showing pictures of what clots look like in the heart has a little outpouching called the appendage. And that appendage tends to have stagnant blood flow in it. And when the heart is in atrial fibrillation, that stagnation gets even worse and clots form in the appendage. And the clots get bigger and bigger. And once the clots get big enough, they break off, and the most common place they go is the brain. Now, they can also go to the spleen and the bowel and the legs, and we consider that a blessing compared to a clot that goes to the brain. So stroke prevention is very important in atrial fibrillation. And we can see those clots. Here's the left atrial appendage on an echocardiogram. And here's a clot sitting in the appendage. And here's a clot that's just attached by a little fiber that's about ready to go and cause havoc. So this is what we have to prevent in patients who have atrial fibrillation. The drugs that we use to prevent clots are warfarin. We don't use it very often anymore. We usually use the 4 newer blood thinner agents, which are dabigatran, Pradaxa. Pradaxa is now off of patent. There's a generic form. So if you're taking one of the other ones, but you're having to pay sort of a car payment in order to get it every month, you might consider trying Pradaxa. Rivaroxaban, which is Xarelto, apixaban, which is Eliquis, and edoxaban, which is Savesa. Aspirin and Plavix are not effective at preventing strokes from atrial fib. They're effective for keeping coronaries open. They're effective for preventing strokes from the carotid artery, but they are not effective. Studies have unequivocally shown they're not effective for preventing stroke from atrial fibrillation. So we use a score called the CHADS-VAS score. So a lot of you know about the CHADS-VAS score, so I thought I would throw this in. But we try to score you on what your stroke risk is. And if you have congestive heart failure, you get a point. If you're hypertensive, you get a point. If you're above 75, you get 2 points. If you're between 65 and 75, you get 1 point. If you're diabetic, you get a point. If you've had a previous stroke, you get 2 points. If you're a female, because females have a slightly higher risk of stroke from atrial fib, you get a point. And we add those up, and you can see that the higher the score, the higher your yearly stroke risk. And somewhere between 2 and 3% yearly stroke risk is when the risk of any blood thinner is much less than the risk of stroke. And that's when we start talking to you about taking a blood thinner if you have atrial fibrillation. So the current guidelines say if you have a CHADS-VAS score of 2 or greater in men or 3 or greater in women, and I could go into why that's different, it's complicated, but for today, 2 in men, 3 in women, if you have a score of 2 or greater, 3 or greater, the oral anticoagulants are recommended, and warfarin is no longer recommended as the first line anticoagulant, even though it's cheap as dirt. So most of you who have atrial fib, and I bet, I don't know what to bet, but I bet there are a good number of you here who know everything I'm talking about because you've been through this with atrial fibrillation management. Now, if you're bleeding from anticoagulation, or if you're one of our Ocala people who gets kicked in the belly every 2 days by a horse, or you're falling off of a horse or something, or I have some bicycle road racers that have made a decision that anticoagulation is too risky, there are ways of obliterating the appendage that don't involve anticoagulation, and that would be a device called the Watchman, which occludes the appendage. There's another device called the Amulet that occludes the appendage. You still have to take aspirin after having these 2 devices, even though you don't have to take a full anticoagulant. And if you can't tolerate blood thinners at all, including aspirin, we can actually put, with minimally invasive surgery, a clip on the appendage to obliterate it. So those are what we do to try to prevent stroke with atrial fibrillation. Now, the next 2 things is we want to get rate control from atrial fib, and we want to consider whether we want to do rhythm control. Medicines are okay, but they're not great. Ablation has a better success rate than medications do, but it's not perfect by any means. And every patient may have a personal decision which direction they might want to go if you want to try to maintain sinus rhythm. I'm not going to talk about surgical ablation today, but there are some surgical techniques also. So we categorize atrial fibrillation as paroxysmal or intermittent, persistent or long-standing persistent. And why is this important for this talk? It's important because intermittent or paroxysmal atrial fib is an earlier stage, and aggressive management of the atrial fibrillation at that stage may prevent the atrial fib from progressing to persistent. Once you're persistent, it's harder to keep the patient in sinus rhythm. And once you're long-standing persistent, more than a year, it's very difficult to keep the patient in sinus rhythm. So if we think a patient is transitioning between intermittent atrial fibrillation that just sort of comes and goes by itself, and persistent atrial fib, which is atrial fib that goes on for days and days and days and days until we do something about it. When we think someone's progressing from paroxysmal to persistent atrial fib, that's the time to think about doing something about it, because if you wait too long, it may be more difficult to maintain normal rhythm. And so paroxysmal atrial fib, persistent atrial fib, cardioversion for interruption is usually needed. Long-standing persistent, notice that the little abnormalities in the heart get more and more and more as you go from one to the other. And this stuff is supposedly representing fibrous tissue or scar tissue in the atrium. As you get more and more atrial fib, you get more and more scarred atria, and it's harder and harder to get you into the normal rhythm at that point. So this is just another example. This is an EKG test. All right, another example of atrial fib. What's this rhythm right here? Sinus rhythm. What happens here? Atrial fib. And if you wait long enough, what happens here? It stops, right? So this is paroxysmal or intermittent atrial fib that you might pick up. You might pick that up on your smartphone monitor. And like I said before, the longer you wait, the more atrial remodeling you have, the harder it is to get the patient to stay in sinus rhythm. Drugs that we use to slow the heart rate during atrial fibrillation, because some of you might be familiar with these drugs, metoprolol or toprol or any of the beta blockers like carvedilol. Digoxin is sometimes used to slow the rate, and diltiazem or verapamil are sometimes used to slow the rate. They do not get rid of atrial fib. They just slow the conduction between the top and the bottom chamber to slow the rate of the ventricles down during atrial fib. In some people, that's all they need to do well. However, other people, you need to try to get them into the normal rhythm. And for that, we use drugs that you may be familiar with, either the generic name or the trade name. That would be flecainide, propafenone, sotalol, dofetilide, amiodarone, or dronedarone. So if any of you are on any of these drugs, it means that somebody is trying to maintain you in the normal rhythm after they've done something to get you there. Do drugs work? Well, the answer is they do work. Here's a placebo. Sotalol is a little bit better, and amiodarone is the best. Another study shows the same thing. Propafenone and sotalol are about 50-50. So either the glass is half full or the glass is half empty from a drug standpoint. So it's reasonable to try a drug. If a drug works, wonderful. If it doesn't work, you either try another drug or you might consider ablation, which we'll talk about in a second. Now, well, I guess we'll talk about now. So ablation is when we actually go in, and atrial fib can come from anywhere in the atria. So currently, ablation is not 100% effective. But we know that atrial fib tends to come from these 4 pulmonary veins that have atrial muscle wrapped around them. So these are called the pulmonary ostia or the pulmonary antra, and that's where we ablate. Now, red means ablated areas and purple means non-ablated areas. Here's pre-ablation and here's post-ablation. And this is what we would consider a beautiful ablation. We've ablated most of the area where atrial fib is likely to be arising, but we've preserved most of the atria. So we want to destroy as much atrial fib tissue, atrial fib generating tissue as possible, but spare as much atrium as possible. If we over-ablate the atrium, we can make it stiff and it doesn't function quite as well. So I like to show this slide. This was an advertisement. Anyone from Houston? Because I don't want to insult anyone. But this was from a Houston paper. Procedure to cure atrial fibrillation in patients with atrial fib. Houston, Fox 26. So anytime I see a billboard or an advertisement that says someone cures atrial fibrillation, this is what I think of that, okay? So nobody cures atrial fibrillation. We manage atrial fibrillation. In fact, as many of you may realize, as we get older, a lot of our medical care is just managing things and not necessarily curing things. So don't trust anyone that tells you they cure atrial fib. Just a little bit of technical stuff. How do we do ablation? We do ablation by going up through a vein in the leg, get to the heart. There's a very thin area between the right atrium and the left atrium. Most atrial fib comes from the left atrium. We do a puncture under echo guidance to go across there. And this is an older slide. We're using radiofrequency energy, but then we do ablation around the pulmonary vein. So that's basically what we do during an ablation. Now, we used to use fire, heat, electrocautery, and that's a radiofrequency ablation. We still use radiofrequency for some types of ablation, but we usually don't use it now for atrial fib ablation. Then we transition to cryoablation. So this is an example of what happens in cryoablation. And this also was better than radiofrequency, but we still had the risk of damaging the esophagus or damaging a nerve that serves the right diaphragm, a breathing nerve called the phrenic nerve. Now we're using what's called pulsed field ablation, which is very specific for atrial muscle and spares esophageal tissue and also does not affect nerve tissue to any extent. And so we think we've made ablation quicker and safer by transitioning over about the last year to pulsed field ablation. And so that's most of what we do for atrial fib. Again, let me remind you, for some other things, we still use radiofrequency ablation. And is it perfect? No, it's not. It's about 80% at 12 months, 70% at 24 months, about 65 at 36 months. But you have to be a little wary of these curves, because these curves are the standard way of assessing ablation, which is time to first recurrence. So when a patient who has an atrial fib ablation goes back and has an episode of atrial fib, they're considered a failure. But if you actually look at atrial fib burden, there are some patients that are in atrial fib 90% of the time before the ablation. They're in atrial fib 2% of the time after the ablation. They feel like it was a great procedure, but they might have been considered a failure on this particular way of looking at it. So we think that the effective improvement is actually better than the formal assessment of success, but not perfect. And if you wait until you have persistent atrial fib, we now have all sorts of things that we've tried to make better ablation for persistent atrial fib. But if we let it evolve from paroxysmal to persistent, and we let that go more than 6 months or a year, it becomes sort of an impossible job to get rid of it. So what are the indications for ablation in atrial fibrillation? Well, symptomatic atrial fibrillation, and now either with or without a trial of antiarrhythmic drug. So if you have symptomatic atrial fibrillation, about half of you would probably say, let me just try this medicine and see how it does. And another half of you would probably say, I hate medicine. I don't want to take something every day for the rest of my life. Let's try the ablation. So we sit down and we talk about the pluses and minuses of either one. Neither are perfect. And so this is a shared decision-making process, physician, patient, family, whatever. If you have heart failure that we think is from the rapid rates of atrial fibrillation, our data are saying that atrial fib in that setting that patient should probably undergo ablation. What to do with the patient with asymptomatic atrial fibrillation is very controversial, and we don't have good data on that. Most of us I don't know what's older and what's younger, so don't throw things at me. But in older patients, we would tend to leave that patient alone if they're asymptomatic. But if it's a 40-year-old or maybe a 50-year-old who's going to be in atrial fib for 30 or 40 years or so, then we actually do think maybe we should try to restore normal rhythm in that particular patient. What you don't do is you should not do ablation in patients who cannot be anticoagulated, because you have to be on a blood thinner for at least 3 months after the procedure, because we make raw areas up in the atrium. We don't want clot to form on that. And it should not be performed in order to get off of blood thinners, because it's not perfect. There's in and out. Even a little bit of the atrial fib might result in a clot formation and a stroke. And that's the worst result that we could get. And I made a little bit too complicated because this is the most recent data on complications. But whenever you do anything, you want to ask me, what are the complications? We used to worry about esophageal damage, but with pulsed field ablation, that's almost unheard of. And that's a blessing, because that is a very major complication. Cardiac perforation still runs about 1%. We keep the patient during an ablation procedure very blood thinned because we don't want a stroke. We can treat bleeding. We can't treat a stroke very effectively. So there is about a 1% risk of some sort of vascular complication from the procedure. Stroke risk is very low because we keep the blood thin during the procedure. This is an old risk from the radio frequency. This does not occur anymore. This is an old risk from radio frequency and cryoablation. This does not occur anymore. Every once in a while, we do have some complications down in the leg where we have to get access for the procedure. I actually think this value is too high because we're using echo now to access the vein down there and have cut down on those complications greatly. Death is extremely rare, but because it's an invasive procedure, or sometimes we might be doing it in a patient who has multiple disease processes going on, it unfortunately is very, very rare, but has to be included. Pneumonia is sort of an anesthesia-related post-operative type of thing. So overall, the risk is around 2% or so of something bad happening during the procedure of ablation, most of which can be taken care of. And there are surgical procedures for atrial fib, especially if you're having cardiac surgery anyway. Our surgeons will do, if things are going smoothly with the operation, they will do an AFib procedure at the time of open heart surgery to try to avoid your having to come back for an ablation in the future. And I think the last thing I wanted to mention was, and I don't know whether anyone in here has had this, but there are some people where we do everything. We do drugs, we do ablation, we do a second ablation, we might do a third ablation, and we just can't keep them out of atrial fib. Some of those patients are asymptomatic, and those patients we just say to heck with it, we're going to leave them in atrial fib. But some of them still go too rapidly and are very symptomatic. In that situation, what we'll sometimes do is, instead of ablating the atrial fibrillation itself, we will ablate the AV node, the conduction system that carries the electrical impulse from the atria to the ventricle, so that now the atrial fib can do any dance it wants, but the ventricles are going to ignore it, okay? Now, the ventricles don't know how fast to go. If you leave the ventricles on their own, they'll go about 20 beats a minute. Most of you wouldn't want to go to the gym with 20 beats a minute because you won't get very far. So we do have to put a pacemaker in. So we call this ablate and pace. And often we'll put relatively sophisticated pacemakers in that will have an atrial lead. They'll have a right ventricular lead and also frequently a left ventricular lead. So that's called ablate and pace. And that's a very useful thing, especially as patients get older. I've had a few patients that we've gone around and around and around with drugs and ablation, and we finally do an ablate and pace. And the first thing they tell me when they come back is, why didn't we do this 2 years ago? But the problem with this is once you ablate the node is ablated. There's no going back, and you're dependent on the pacemaker at that point. So I'm just going to end with an ending slide. If you go into Shands, the old building has all these little tiles that children have made over the years, and I have a favorite. My favorite tile is right there, which is love heals the heart. So I will take any questions. You want to do questions now? So I think I kept that a little bit like what I would talk to a patient in the office.
Well, Bill, thank you very, very much for that. That was really a wonderful talk, perfectly paced and perfectly pitched. And I just want to personally thank you for doing that. So let's get to the questions, and I'll give the microphone to the person with the answers.
You got another mic?
Two questions, if you will. One is, does a pacemaker, if someone has a pacemaker in but is not having atrial fibrillation, does it help keep the atrial fibrillation away or have no effect or negative effect?
Studies have been done on that, and special modes of pacing have been tested. There may be a mild effect in some patients, especially patients that were having a lot of really slow heart rhythm before the pacemaker. but it's not a very prominent effect.
No.
And I'd like to add, the one thing though that is extremely valuable is once you have a pacemaker or a defibrillator put in, it does act a little like a spy, and it monitors for atrial fib. And if you start having a fair amount of atrial fib, we know at that point that we may need to start discussing anticoagulation issues with you, or you might be able to correlate times that you don't feel well with times that the pacemaker says you're in atrial fib. And that's also a help to us. But pacing directly has a little bit of effect, but not a strong effect on preventing atrial fib.
Thank you. The second question had to do with the Plavix. You mentioned that Plavix does not help reduce atrial strokes from atrial fibrillation. Does it have any effect on strokes not originating from atrial fibrillation?
Yes, it does. And so anything that has to do with small vessels, and stroke-wise, the smaller vessel would be the carotid arteries or some of the branches of the carotid that go up to the brain. Plavix and aspirin are platelet inhibitors. Those make the platelets slippery. And in small arteries, the platelets sort of congregate, and then little pieces of the platelets break off and cause TIAs, transient ischemic attacks, if you're familiar with that, or smaller strokes, or sometimes cerebellar, strokes in smaller areas of the brain. The difference is the appendage is a large sac, which gives the opportunity for the clot to get bigger and bigger. So not only is it platelets, but the actual protein called fibrin gets deposited around that clot. And fibrin is not, that fibrinization of the clot's not inhibited by
So the clots can form there even if you don't have fibrillation?
They could, but not commonly, because when you're not in atrial fibrillation, the appendage, which is heart muscle, is actually contracting vigorously. Okay. So it doesn't have anywhere near as much stasis. So there's a small chance of having a cardiac related clot in someone who's not in atrial fib, but it's small. A comment though that I could add to that is if you have atrial fib, the clots and the strokes sometimes occur at times when you're not in atrial fib. Because what happens is the clot forms in the appendage while you're in atrial fib, then you convert back to the normal rhythm, and then that clot, now that you've converted back to the normal rhythm, the appendage begins to contract vigorously and might even have more of a chance of throwing that clot out. So you don't say, oh, I'm not in atrial, I've been in atrial fib for 5 days, I'm not in atrial fib today, let's stop my Eliquis. That's a conceivable, potentially bad decision.
Thank you. Thank you very much.
And I have patients that do that regularly. Yeah.
Go ahead, Bill.
Thank you.
Yeah.
We have some old-fashioned Apple Watches. They don't do the heart rate, but they do measure heart rate variability. And they do send out a message when it thinks that you're in AFib.
Yeah.
And we've had 1 or 2 short events, but they are a peak in heart rate variability. I don't know if that's really AFib or not.
One of my colleagues and I have relatively strong disagreements about that, because I deal much more with atrial fib than he does. So I have an exercise nut colleague who says, oh, I just love the heart rate stuff and the heart rate variability. But as someone who deals with atrial fib, if you take that Apple Watch and go like this, and you roll over on it at night, and you have some premature atrial contractions and some premature ventricular contractions, the heart rate monitors give a fair number of false readings.
Mhm.
So we actually do feel it's good to have that because it might be a warning to do more careful monitoring, but in itself, it's of only moderate reliability. And we would never treat anyone on the basis of that unless we had better documentation.
Mhm.
So I encourage people to upgrade their, I don't work for Apple, but I think the actual rhythm strips are so valuable that that they're very helpful to us. On the other hand, if you came into a doctor's, an electrophysiologist's office and said, here are my heart rate variabilities and my heart rates, I have these spells where I'm not really doing anything too funny and it shouldn't be artifact that it looks different, that could prompt him or her to put a monitor on you for a month or something and see what it really is.
Thank you.
Yeah.
So let me read one of the questions from the Zoom audience. Can warfarin ever be changed to the new drugs, a new drug such as Eliquis?
Yeah, very easily. But there are a couple of times when we use warfarin specifically. And usually severe mitral disease or a mechanical prosthetic mitral valve. So, and are there some, you know this more than I do, are there some factor deficiencies that you do warfarin for rather than the factor 5 laden or something?
That's kind of outside of my.
Okay, I didn't know what,
We
it's
call-
outside of me too.
Call
But
hematology.
from a cardiology standpoint, as long as you don't have a metal mitral fake valve or severe mitral stenosis, which is obstruction of flow across the mitral valve, Eliquis is probably a reasonable choice. And what you do is you just do if you do home INRs, you just do you stop the warfarin, you do INRs every day until it drops below 2. And when it drops below 2, you just start the Eliquis. There are a few disadvantages. There are a few people that have had a clot or a stroke or something while taking Eliquis. It's rare, but it happens. Sometimes we switch them back to warfarin so that we can actually measure the effect because it's difficult to measure Eliquis effect on a blood test.
Thank you for this talk. It's really informative. In addition to the drugs used, can you speak to the effect of exercise for improving the situation? Does it?
Yeah, we think that the things that have been studied the most have been diabetes and weight, glycemic control and stuff. But exercise is an integral part of weight loss and an integral part of diabetes control. So we think exercise is a very important integral part in doing this. Now, I don't know whether you're aware of this. There is one thing that's a little paradoxical, and that is runners who are extremely well trained actually are known to have a higher incidence of atrial fib. And we don't know exactly why. It seems to be most common in runners. We don't see it much in swimmers. The type of exercise and the physiology of the exercise between the two is different. So I think for most of you in here, mild to moderate exercise on a regular basis is going to be a favorable thing. It makes diabetes better, it makes weight better, it makes obstructive sleep apnea better. The only thing is you might have a grandson, who's sort of a crazy runner who has atrial fib, and we do see that type of stuff. Hard to deal with atrial fib in a real young person who many of these people are, you tell them to decondition a little bit and they look at you like you're from Mars.
Is
Is AFib considered to be a progressive disease where it's expected to get worse and worse as time goes by? And also, when you're in the midst of an AFib event, what is your best recommendation? Do you take an antiarrhythmic medication, or are there other things you should be doing?
Well, the in first part of your question is in many patients, it is progressive. And we think it's a little bit like if you stamp it early, if you stamp on it early, you can delay the progression. You may not negate the progression, but you can delay the progression. There are a few people where it seems to be stable over a long period of time. But in many, I would say the majority, you have, especially paroxysmal people, have to watch out that they're not evolving into persistent. And we have reasonably good data that if you do a nice ablation on a intermittent or paroxysmal atrial fib patient, it sort of returns them to a baseline again, although they may progress again slowly. And 5 or 8 years later, you might have to do something else. The second part was, what do you do during an atrial fib episode? If you feel really bad, if you're really short of breath, if it's the first time it's ever happened to you, if you're having chest pain, you go to the ER. But the ER is a zoo. Any avoidance of the ER is usually good. So if you know atrial fib, if you recognize atrial fib, and you don't feel very bad, and you're in atrial fib, and you know you usually go in and out, try to avoid going to the ER. You might try to call your physician and tell him, and he may give you advice. But a lot of times we've already given our patients that advice because we want to keep them out of the ER. And one is, if you're on a rate slowing drug like metoprolol, and you go into atrial fib and you're going rapidly, take metoprolol or take an extra metoprolol, and that'll slow it down enough that it's not very symptomatic, that you can go take a nap or something, and often when you wake up, it'll be gone. In people where that doesn't work, there are some of our antiarrhythmic drugs, especially flecainide and propafenone, that we can give in a form that we call colloquially a pill in the pocket. So you don't take it on a regular basis, but if you go into atrial fib, you pop maybe a double dose of the medication, and again, go take a nap or something and hope you wake up without atrial fib. So there are pill in the pocket for people whose atrial fib's not highly symptomatic. The pill in the pocket with either a beta blocker or flecainide or propafenone is a relatively common way of dealing with it. But if you're very symptomatic from your atrial fib, you're better at preventing episodes than you are trying to deal with episodes that you have. We often tell patients, if you're not real symptomatic and if you recognize what it is, do whatever we've told you to do for 24 to 48 hours before you say, well, this isn't going to go away. And don't miss your anticoagulant.
What is the difference between atrial flutter and atrial fibrillation?
Oh, I was afraid someone would ask that. I avoided that. But atrial fibrillation is usually a left atrial-based rhythm, which is very disorganized and probably consists of multiple abnormal areas either firing at the same time or multiple little things that we call rotors. I have a slide of a hurricane going over my son's house in Fort Myers that I then have a picture next to it of an atrial fib rotor. So nature likes rotors, whether it's Hurricane Ian or whether it's atrial fibrillation. So atrial fib is multicentric, comes from multiple areas of the atrium, and probably has a variable type of one area going one rate, one area going another rate, so that the whole thing looks like chaos. A first cousin of atrial fib is atrial flutter, what we call atrial flutter. Some patients think they can feel flutter, but usually they're just feeling type of atrial fib. But atrial flutter is a more organized rhythm, where the most common type, for example, goes around and around the right atrium. And if you always have that common type, we can do a relatively straightforward ablation to take care of it. But there are also left atrial flutters. Atrial flutters, as far as blood thinners are concerned, should be treated exactly like atrial fibrillation, and they're basically first cousins. If you have atrial flutter and we do an atrial flutter ablation alone, you have about a 30 to 50% chance of eventually coming back with atrial fibrillation also. So if any of you come into clinic with EKGs that show atrial flutter, we'll counsel you on whether you would like to stage things, do a relatively simple atrial flutter ablation and see how you do, or since you have such a high risk of having both, whether you want an atrial fib and flutter ablation in a one-time ablation. But flutter is organized. The issue with flutter that might be important to you if you've experienced flutter is flutter generally is associated with more rapid rates than fib is. So sometimes it's more symptomatic.
So let me take another from Zoom, and then we'll get back to many of you who are still in atrial fibrillation about putting up your hands.
I didn't want to take a poll for how many people were in atrial fibrillation.
Would be an interesting poll.
Yeah.
But can amiodarone cause heart rates in the low 40s?
Yeah, amiodarone is a rate slowing drug. So amiodarone will commonly, now not everybody gets slow heart rates from amiodarone, but amiodarone commonly slows the sinus rate.
Okay, anybody?
And that limits its use in some people.
Dr. Miles, I'm here because I'm getting ready to go see my cardiologist, so I'm going to take some of this information. Pardon? Okay. I got it. Can you hear me? Well, then it's being held correctly. I'm an international healthcare worker, and I was in Africa 7 months ago. I was there for 5 weeks. I was with a country that collapsed completely. I came back with severe dehydration and 31 hours with multiple connections to get back from East Africa. I came home and I went into atrial fib. I took myself into the emergency room, which I agree with you because I had to do it again, I wouldn't. But anyway, I told him I am in severe dehydration. And I did not see that as one of your reasons.
That would be sort of a one-off, sort of a
Yeah.
relatively rare situation in the United States. But I think that you make a good point that I think someone who's dehydrated probably not only is water abnormal, but sodium and chloride and potassium.
My GFR was 50, and they tried to tell me I was in stage 3. I said, I am not in stage 3.
You just need a couple of bags of
D5,
fluid. Yeah, right.
And it went back up to 72.
So what I might do, if I could jump ahead for a second, if you came in and told me that was the only episode of atrial fib that you've ever had,
Right.
and you give me this nightmare of a story of getting back, I think that a situational cause of a situational thing like that is likely to have been related to your atrial fib. So you still need a thyroid test, you still need an echocardiogram, and it might
I had
not,
all of those.
and it might not be a bad idea to monitor you for a little while just to make sure that there's no ongoing atrial fib that you're not aware of. You know, people say, I can feel every time I'm in atrial fib, and then you put a monitor on them, and atrial fib's like a iceberg. They can feel some of it, but not all of it, and especially at night. So I would say that if you're not having if you're not having any atrial fib clinically, if you have a structurally normal heart, no hyperthyroidism,
No.
a good clinical judgment might be to just sit on it.
Just depends.
But if you have a second episode, and this is where a home monitor might be useful, if you have another episode of feeling poorly, document whether it's atrial fib or not.
Well, it's been 7 months, and I am one of these people that I am not giving up the work that I'm doing. So I'm going to talk to her if she disagrees with me about approach the left atrial appendage.
Yeah.
If
So someone who travels into areas where medical care
I'm the only medical care.
might be limited, that is a acceptable indication for a Watchman or an amulet type left atrial appendage occluder. Did your physicians think you had enough evidence of atrial fib that they have you
I had it
anticoagulated?
documented and
Yeah.
was able to take it in and show it
Yeah.
to him. Plus, I read my own EKG. The other thing
And
is,
it also depends on what your Chad's VAS score is. So I don't want to ask you what your age is or whether you have diabetes or.
I have
whether you
nothing,
have- yeah.
nothing except this one episode.
So if you have a low Chad's VAS score in one episode, this is a gray zone, but a lot of physicians would, with shared decision-making with you,
Well, I'm going to ask
could
you one
wait.
because my concern was Eliquis, because I am the only medical care available to where I work. So if I have a bleeding episode, so the question
Yeah.
is, do you come off your medication
It-
when you go in these
That's a
circumstances?
good question. It depends on a lot of information that I don't have. So,
I'll be asking her about it.
yeah.
Okay.
But it is going to be it is going to be a little bit of a gray zone.
Okay, I don't see any other takers, so
Right.
I want to say thank you very much.
All
That was
right.
great.
Great.